Okay, here we are a little bit later than usual, but nonetheless we are here on Good Friday and National Doctors Day for our latest edition of COPD Navigator Live. My name is Mike Hess. I'm a respiratory therapist / COPD educator, and we bring this to you every Friday, just about every Friday. I'm going to say that right before I take a couple weeks off, but we come to you live Fridays, noon Eastern Time approximately. With the latest and greatest information from the COPD research, plus educational topics of the week, and of course your questions answered live. Be sure to get those in right away so that we can get to them toward the end of the program today. We are getting started a little bit late today. Did have a conference call with the COPD Foundation where we are looking to do some more educational surveys and stuff like that. So that is the reason for my tardiness today. I do apologize for that. So let's go ahead and jump right in as everybody is getting their respective questions in and all that kind of fun stuff. We start today, as we like to do every week, with some news. And as soon as I get all my windows in order here, the first news item we're going to look at is out of a journal called Primary Care Respiratory Medicine, looking at the effects of aspirin with the severity of COPD exacerbations. This was a study that was done by a group based out of Massachusetts General Hospital in Boston, covered by their Institutional Review Board. They wanted to look at how aspirin as an anti-inflammatory type of drug can potentially affect COPD exacerbations in the general population. So they looked at databases from 7 states across the country, looking at over 200,000 patients, on approximately 14,000 of those according to their ICD-9 or ICD-10 codes that are part of the whole diagnostic medical records process. About 14,000 people in that group were chronic aspirin users, people who take that baby aspirin every day for a variety of other reasons. They wanted to see how that can possibly affect COPD. And what this group found was that it didn't necessarily prevent COPD exacerbations, but in those people who did end up in the hospital, they found that those people who were using chronic aspirin were found to have lower mortality. Fewer people died while in the hospital. They had a lower incidence of being put on a mechanical ventilator, the invasive kind with the tube and all that kind of stuff in the intensive care unit. And they also had a decreased length of stay, which means they spent less time in the hospital. While the group wasn't able to find what we call a causal relationship or a direct impact of aspirin leading to a lot of that stuff, that is kind of the next step in the process. And with aspirin as cheap as it is, they figured that this could be a potentially solid method to, if people are going to end up with exacerbations, to try to minimize that impact. Of course, we all know that the more severe an exacerbation, the longer that goes on, the more it impacts your quality of life and your respiratory function once you get out of the hospital. So if we can minimize that impact, that is a very good thing. Next up are two particular items that are kind of related to our topic of the day, which, by the way, is going under the knife, some of the surgical and mechanical interventions for trying to treat COPD, particularly in the more advanced phases of it. This next item was published in a journal called Chest, which is a journal of the American College of Chest Physicians, and looked at how we evaluate or how we predict survival after lung transplant in those people who are candidates for it. One of the most common ways to do that is what's called the Bode score, the Bode score, where it looks at your BMI, the level of obstruction as that percentage of the FEV1 compared to everybody else, and your height and age and gender and all that stuff. Your level of dyspnea, which is the D there, which is calculated by the Medical Research Council scale, which is a measure of how well you're walking around, that sort of thing. And your exercise tolerance as measured by the 6-minute walk distance. So looking at all those things, that's kind of been the classic way to evaluate whether somebody is part of the evaluation process to decide if somebody is a good candidate for getting a lung transplant. Because they figure that this whole multi-spectrum analysis thing gives a really good impact or a really good analysis of how well somebody is going to tolerate that procedure. But what they've found, especially in this study of about 5,000 people over the course of 25 years from the late 1980s on to, I believe it was 2014, I think it was 89 to 14, they found that while anticipated that the highest quartile, the top 25% of people, the people with the highest 25% of those Bodhi scores were expected to have the lowest expected survival rate afterwards. So what they did was they compared the majority of this 5,000 patient group were people who actually were candidates enlisted for lung transplantation. Took a look at their scores as compared to the original validation group for the this test, this Bodhi score. And found that actually people who the bottom line is the Bodhi score tended to underestimate their mortality. They tended to live longer than people would have expected based on that score, based on some of the original assumptions that underlaid that score. The reasons weren't entirely clear. There was some thought that the screening process for somebody getting a lung transplant could weed out some of the people who maybe had more severe comorbid conditions, those conditions that go along with some of the heart or the lung stuff that goes on. And they also found that in the group with lung transplants, there was also, as you might expect, a lack of smokers. One of the main criteria we'll talk about in a little bit when we're talking about lung transplants is you have to stop smoking. And of course, we know that whether you get a transplant or not, people who quit smoking do tend to have better outcomes down the road. They have a little bit higher quality of life. They have a little bit lower risk of early mortality. That kind of gets put off a little bit. And so they weren't 100% sure exactly what was causing a lot of that stuff. But they found that this group that was expected to put it bluntly, to die sooner was actually surviving on the median, not quite an average, but the middle of the road life expectancy was about 5 years, which was pretty in line with a lot of the other transplant expectations. So this is kind of, again, this is a little bit early research, but maybe we should reconsider exactly how we're scoring and how we're anticipating how long somebody is going to survive after that lung transplant. Of course, we had a question in our group here on Facebook, copdnavigator.com. If you're new to the program, facebook.com/copdnavigator or copdnavigator.net. Anyway, our group is, there was a conversation in the group earlier this week about how long can somebody expect to last with after a lung transplant. And that's what we're finding out now. We'll get into more detail in a little bit in a few minutes. But we're finding out now that some of our assumptions about life expectancy and things like that really did follow the traditional, you know what they say about assuming. They really did follow that model of kind of making an ass out of all of us clinicians out there. So we need to reevaluate how we're looking at potential candidates and make sure that we're doing a good job finding people who are going to get the most benefit from this procedure. Our last piece of news today, we've looked at this a little bit before, and hopefully I successfully turned the volume down this time around, but MD Magazine has done a couple of these roundtables here with a couple of prominent pulmonary physicians, including Dr. Byron Thomashow, who is chair of the board of directors of the COPD Foundation, and Dr. Barbara Yawn, who is a primary care physician, who is very engaged in COPD education and research. And this panel, specific this time around, was looking at the future of COPD management. And what this comes down to, and again, this ties in very nicely with our topic of the day, the idea of personalized medicine, the idea that we really need to be targeting therapies toward the individual case. Every case of COPD is a little bit different. And while we can have very good clinical guidelines and recommendations and strategy guides and all that kind of stuff, we really need to be looking at the individual case, the individual setting of the person, what other disease processes they might have going on, what their social structure is like, anxiety, depression, all that kind of fun stuff. And we really need to be looking at the results of some of these studies that are going on out there. Again, a conversation in the group this week was, are there any new therapies on the horizon and new treatments out there? And there's a lot of research going on right now, particularly in the realm of genetics. We're looking at some of the genetic processes that guide who comes down with COPD, why it tends to progress faster in some people, it doesn't really progress in other people, why some people stop getting damage when they quit smoking and other people don't. We're really trying to look at those processes right now to get a better understanding of how that works. Another thing that Dr. Yuan brought up were some of the new medications, especially biologics out there, things that are derived from other enzymes and stuff that comes out of your body to help reduce the progression of some of that stuff, rather than just all these synthetic molecules that most of our inhalers and stuff like that are made out of. But the biggest takeaway was we really also, while we're waiting for a lot of these studies to come out and a lot of these new therapies, we do need to get back to basics. We need to be working hard on prevention. Of course, smoking cessation is a big thing of that, but also a lot of environmental pollutants. It's not just cigarette smoking. This is not just the smoker's disease. We need to be looking at some of the other causes out there, pollution, wood smoke, all that kind of stuff. We need to be getting back into education. We need to be making sure that people know how to operate their therapies, know how to use their inhalers, know that clinicians need to know that pulmonary rehab is still a thing and can work very well for people. And we need to, again, personalize that care based on the individual cases. So that's really the big takeaways there. You can follow that link at the bottom of the screen. I encourage everybody to, it's not a very long video, but it is very informative with some of the heavy hitters in our COPD research world right now, and it's always good to get some of those insights. Now, those of you who have watched the program before may realize that I'm dressed a little bit casually today. I'm wearing a t-shirt. One of the things that I usually say about our group is that we are very agnostic as to we aren't sponsored by anybody. We don't take any sponsorship money. We don't do any of that kind of stuff because everything needs to be as objective as possible. And that's still the case here. Don't worry, I didn't get any money or anything like that for this promotion. But I also like to encourage everybody out there to, I like to make sure everybody's aware of all the equipment and all the stuff that's out there that can potentially help, especially when it comes from the lung community itself. And so what I'm wearing today is a t-shirt from a company called O2 Safety Strap at o2safetystrap.com. Safety is in their product name. And what this is I forgot to advance this here a little bit. This is a piece of equipment that was created by this gentleman named Sam Hall, who you see wearing the safety strap below. Sam is a chronic lung disease patient with sarcoidosis, actually becoming kind of a rock star. He's going to be giving a keynote address for the Bernie Mac Foundation coming up here before too long, down I believe in Chicago. And Sam's story, I'm going to share this from his website here. He said, I wanted to take a moment and share my personal story testimonial with you the consumer, about the inception of this product. He has had to be on supplemental oxygen for a long time and found, like many people do, that the cannula line that leads from the tank up to your nose is a problem that just gets in the way all the time. He says that he tried everything from taping it down to pinning it, even holding the tubing. That didn't work. Of course, when you're holding stuff, you're losing that hand and all that stuff. One day in particular, he was bringing in groceries. His cannula caught the doorknob and made him fall and tear up his knee pretty good. And so that got him to thinking that, of course, there must be a better way. And so one night he thought, what if I rerouted the cannula line over the shoulder instead of letting it dangle and enclosing the tubing so it didn't tend to catch up on stuff. And so thus the O2 safety strap was born, a simple yet effective product that fits most cylinder bags, portable concentrators, clips to itself, all that kind of fun stuff. This is a fairly inexpensive product. Of course, it's difficult for me to do the product evaluation like we've been doing for a few weeks now because I'm not an oxygen user myself, but this is an excellent, innovative product that I think everybody potentially, if you're on supplemental oxygen, can take some advantage of. Sam is a friend of mine here on Facebook, and he asked if I could help him spread the word on that, and so of course I'm very happy to do that. Again, this is not a paid solicitation or commercial involvement or anything like that. This is somebody in the community doing good work on behalf of the community, so I like to encourage that whenever possible. So everybody can go to down at the link below, o2safetystrap.com. Check that out. You can order right from Sam and get all that stuff going for you and make yourself a little safer at the same time. So So now with all the news and all that kind of stuff going on, that is now out of the way. So now we're going to talk about our topic of the day, which is going under the knife. A variety of interventions and stuff like that that aren't medicinal in nature, but can definitely have an impact on the quality of life. Now, of course, the big gun here, and one of the things, the most involved type of procedure, we'll say, is of course the lung transplant. This is one thing that of course a lot of people know. We have multiple group members who have gone through the transplant process, and of course this is arguably kind of our most definitive solution to COPD these days. Until we get to the point where we can do the stem cell stuff effectively and regenerate the tissue and all that, basically taking it out and putting in a new set is our most definitive solution. The process started back in the 60s. The very first lung transplant were back in the 60s, but as I learned in a presentation what was it? I think that was a couple of weeks ago now. We've only really been doing effective human lung transplants for about 30 years. This started in the the early 1980s when we had some more powerful antibiotics, where we were able to get some of the rejection and some of that stuff under control a little bit better, some of that infection control sort of thing. We've really only been doing this for about 30 years. So as procedures go, this is still a relatively young one. We do about 4,000 procedures every year this year, mostly what we call double lung transplants, where you're getting the whole match set out. When these transplants first started, the majority of them were actually single lung, where you only got one donor lung. But nowadays, especially, we do see a bit of an advantage in survival. We do tend to do the double lung transplants. Of course, there's a lot of stuff that goes into deciding whether somebody would be a good candidate for that. There are extensive procedures, and those of you who have spoken with anybody in the group who's gone through this process can tell you it's no joke. This is a very thorough process, because this is a very thorough procedure. This is a major surgery, as you might expect. So some of the general selection criteria, and again, this is going to vary just depending on your particular transplant center and some of the individual regulations that might your transplant physician might put onto you, I should say. The most general selection criteria is you do have to have severe disease. You have to be fairly advanced. This isn't something for somebody who's just taking albuterol from time to time. This is something that you only do when you're having a major impact on your quality of life, and the more traditional medical procedures have kind of reached the limit of their effectiveness. When you're on your maximum inhalers and you've gone to pulmonary rehab, you've done all that stuff, you're doing everything that you can, and you're still not living a decent quality of life, then you're starting to look at in the transplant area. To that effect, your risk of death has to be greater than 50% over the next 2 years. I don't know exactly how they create that criteria, but there are a lot of different tests that we do in order to get people, the pulmonary function test, the blood gas test, all that sort of thing. It has to be felt with your clinical team that your risk of dying is greater than 50-50 over the course of the next 2 years without a transplant. The companion to that is you have to have a likelihood of survival at least 90 days after transplant of 80% or more. So this means your comorbid conditions that we talked about a little bit earlier, they have to be under control. You can't really have a lot in the way of cancer or any of the other kind of dread diseases out there. You actually have to have, that's another one of the criteria, is the absence of non-pulmonary comorbidities that limit life expectancy. Like cancers, like major heart disease, a lot of that kind of thing that can be a bit of a deal breaker for me. Basically, the concern is this is going to be, not only is it a major insult to go through the process, but this is going to be a heavy strain on your body after the fact. And so they want to make sure that you have a reasonable likelihood of being able to survive all that complication. You also have to have a psychosocial evaluation, which I think is getting to be kind of standard with a lot of surgical procedures these days. I had to have a psychosocial evaluation when I had my bariatric surgery. Because a lot of these surgeries are major lifestyle changes too. It's not just a one and done. It's not like getting a rod in your leg or something like that. Even then, that has complications. This is something that affects you for the rest of your life, as you might expect. When I was at that lung transplant presentation the other day, another complication of doing the lungs, as opposed to things like kidneys and livers and stuff like that, is that the lungs really are the only organ that are still exposed to the environment even after transplant. When you get a new liver, or you get a new kidney, or even get a new heart, you have your body's innate protections, your skin and the rest of your muscles and everything else that kind of helps protect that organ even after transplant. With the lungs, they're still exposed to everything that is around you. They're open to the air, essentially. Otherwise, what's the point? And so there's a higher risk of complications with lung disease, and so you have to be able to bear that burden and operate successfully with that after the fact. And finally, they want to make sure that you have a good support system in place. Again, this is not something you're going to want to do alone. This is a big change. This is a heavy recovery period. And this is something that you need to have that quality support in order to make it happen, to give you your best possible outcomes. And so, another thing that limits the amount of transplants that we can do is the fact that we just don't have enough organ donors. Of course, this is something that many organ transplantation specialties, disciplines would agree with. There aren't enough kidneys to go around, there aren't enough hearts to go around, there aren't enough a lot of things to go around. Part of that is probably arguably a good thing, because it means that people aren't having catastrophic injuries that they can't recover from. But even people who may be potential donors, when that tragedy happens, we're not doing a good enough job of, recruiting, so to speak, and making sure that donor pool is adequate for our needs. Now, of course, there are some very important considerations for that. Of course, as I mentioned, today is Good Friday, and a lot of people have religious objections to organ donation, and of course that is completely understandable. However, those people who maybe just haven't bothered to check the box or talk to anybody about wanting to be an organ donor, we still need to make sure that we're encouraging people, dispelling some of the myths out there about organ donation. Clinicians don't give up on you if you're a potential donor so that they can harvest the organ. We're still bound ethically to do everything we can to help you while you still have all your organs. The concept of organ donation is simply when you get to a point where you cannot use that organ anymore, it can go to somebody who can. And again, I'm very pleased to call a few people in the group friends who have benefited from organ donation. It's an incredible process, and so I hope anybody out there, please talk to friends, family, loved ones, strangers on the street, whoever you can. Encourage that concept of organ donation, because we definitely need more. In addition, we talked a little bit earlier about doing that single lung versus double lung. When the process first started in those early 80s, we did tend to see more single lung as a percentage of overall procedures. We saw more single lung transplants than we do double lung transplants. Simply because that was the idea at the time, is if you could have one lung and something went wrong, then you still have your original lung even though it was sick and all that kind of stuff. Nowadays we do have evidence that double lungs do tend to be, this is a very subjective thing in a lot of cases, do tend to have a little bit better outcomes, a little bit longer longevity, that sort of thing. However, it is more difficult to match up that pair. There's a lot of stuff that goes into it, from blood types to the point to the whole lecture that I was attending the other day was what they call humoral immunity, where some of the fluids that are inside your body all have enzymes and antibodies and all that stuff, and a lot of that has to be taken into account when you're trying to match that donor organ with the recipient. And so sometimes it's just more practical to give somebody a single lung transplant and help them, again, increase that quality of life and increase where they are, rather than keeping them on the list and risking death with that. We do see improving survival. Again, we talked a little bit earlier about whether our predictions are a little bit inaccurate or not. A lot of this stuff, every time one of these procedures is done, the clinicians involved in the process, they learn something from that. And so we're taking that and improving the processes. We've got new technology coming out that is improving the ability to maintain the tissue. A lot of the issue with lung transplant is we simply can't get the matched organ to the person in time. If somebody donates in Florida and needs a lung in Washington State, it's difficult to get to match that up and get all that logistics going. But there are new techniques all the time, including here in my home state. The University of Michigan is doing a lot with that extracorporeal, outside the body, lung maintenance and all that stuff. And we're also improving we're better targeting matches, again, looking at the different factors in immunity, and we're doing a better job at supportive therapy. We're doing a better job at targeting the anti-rejection drugs. We're doing a lot better job with personalizing a medication regimen to maintaining an individual's quality of life. So while the median survival, they call it, again, that middle range, where half the people are higher and half the people are lower, not quite an average. It's a kind of a ticky-tack statistical difference, but it is there, is about 6 to 7 years. That number is increasing all the time, and so it's very important we continue to do research in this area, and we continue on to continue to make things better. Some of the things that might prevent you from getting a lung transplant, if you have an uncontrolled or untreatable infection throughout your body, some of those, the chronic infections, I believe hepatitis is one of those. If you have that virus floating around, HIV, things like that. If you have an untreatable infection, it doesn't have to necessarily be the traditional bacterial infection, but that's a strike against. Again, neoplasms, cancers, that sort of thing. If you have other major organ dysfunction, if you have major liver disease, if you have major heart disease, that can be a contraindication. Again, this is something that is a big deal, and we want to make sure that you're strong enough and the rest of your body can support having that procedure done, so that we don't end up putting good lungs into somebody that doesn't have a chance anyway, and taking an opportunity away from somebody else potentially. Nutrition can be a factor. Major obesity is an issue. Similarly, being underweight can be a problem. Tobacco use, again, we talked about that in that cohort of people with the Bodie index and survival rates. You can't be a smoker for a lot of reasons. Obviously, we don't want to. It's going to be difficult enough to keep the new lungs healthy. We don't want people to be doing stuff that is actively damaging them. But in addition, smoking can affect your healing. And of course, being such a major procedure, you need to be at your best possible healing condition, and nicotine and some of the other substances in tobacco can affect that. Similarly, drug and alcohol abuse, and then psychosocial issues. If you don't pass that screener, that's going to be a barrier. A lot of people feel that age is a barrier, but 1/3 of the lung transplants out there are actually in people over 65. Especially as we see COPD being a major indication for lung disease or for lung transplant. It's an older population. We're trying to get better at catching it early, but it does tend to be an older population. And so we do see people with decent quality of life and decent longevity even after 65. Once you get up around 75, then we start seeing, it's maybe a little bit more of a contraindication. Again, you have a lot of other stuff lined up against you at that point, as far as healing and recovery and all that kind of stuff. But it is, just scrolling back at some of the other comments here, make sure I'm not missing anything that I want to cover right away. But it is something to consider. One of our group members, a longtime friend of Navigator, Uncle Jim Nelson, who of course is another very vocal advocate and a double lung transplant recipient himself, who goes around advocating for COPD awareness, transplants, all that kind of stuff. He sums it up very well whenever you talk to him about transplants, and it's basically trading one chronic disease for another. And that's something you need to keep in mind when you're considering a lung transplant. Of course, you're recovering from the lung disease and you have an opportunity to be in much better respiratory shape, But you also have you're on chronically on anti-rejection medications, antibiotics. There's a whole. He's got some slides with his daily medication regimen that would put any local pharmacy to shame. There's a lot of stuff that goes into the post-transplant regimen. I've talked to a couple of other recipients, and there are changes in diet. You have to be careful about some of the preservatives and some of the other food additives that you take in, the medications. You have to be careful when you're around other people. You have to be very on guard with the potential for carrying on, taking in infections. It's not just a magic bullet or anything like that. It is something that you have to go into with your eyes wide open, and have a very good relationship with a variety of clinical teams, from your transplant specialist to your primary care provider to a lot of infection control. There are a lot of people involved in the process, and everybody has to be open and communicating. Everybody, you all know I love to talk about rowing the boat together. Everybody's got to be rowing in that same direction, so that everybody can have the best possible outcome. Talked a little bit about the median survival is about 6 years, a little bit better for the double lung people. There are a lot of factors involved in trying to predict that, and so it makes it very difficult to say, well, you're going to get new lungs, you're going to live for this long. We're learning again more and more about how various forms of the immune system works, how they all intertwine together, the percentage of the match, the quality of the match. That can have a big impact, not just the physical match, but the chemical match, the biochemical match. There's a lot that goes into it, and so it's important to note that it is improving, and also to consider that it might not necessarily add years to your life, but it will certainly add, in most cases, add life to your years. So all things that need to be considered when you're contemplating undergoing or being considered for a lung transplant. Janice does throw in there, is the age now 70 for transplantation? I was just looking at a resource called Up to Date, which is kind of one of the major clinical resources that we use in the clinical realm to make these decisions. And according to that resource, it was actually more like 75. It's what we call a relative contraindication, where it's not an absolute hard no for anything. But we do have to consider that the older you may be, the less likely you are to have what we consider positive outcomes. So if you have a 70-year-old who has COPD, is struggling with all that stuff, but is in otherwise really good health, that might be a pro. Whereas if you could even have like a 60-year-old who has a lot of comorbid factors and a lot of other issues going on, where they might be not as good a candidate. So I don't think there is officially a hard and fast rule. If it is, it's going to be more up in the 75 age range. Again, a lot of this stuff is relative just to the case and to everything else going on. So of course, the full-on transplant procedure might not be everybody's cup of tea, so there are some other options, of course. And the biggest one, or the most prevalent one, is probably what we call lung volume reduction surgery, where they actually, let's see if I put that up there. It's not fully understood how it works. It has kind of a fun name I discovered today, reduction pneumoplasty. I think that's funny, the idea of everybody talks about rhinoplasties, nose jobs, and then transferring that into the lung. I got kind of a chuckle out of that. Plastic surgery for your lungs, cosmetic surgery for your lungs. But at any rate, we don't necessarily know precisely how it works. Of course, the suspicion is that by removing some of the damaged lung tissue, that when you have emphysema, you have kind of that stretching out of some of the lung tissue. It takes up a lot more space to do less good. If you're able to take that away, the healthier lung can expand a little bit more normally and improve what we call the recoil, the elastic recoil of the lungs. When you take in that breath, in a healthy lung, it's like a balloon. It wants to push everything back out and help you exhale. With emphysema, you start losing some of that elasticity. And so you take that breath in, and it takes a lot longer to push that breath back out, because it's like trying to deflate a plastic grocery bag rather than a latex balloon. And so by removing some of the damaged tissue, we believe that we improve some of that elastic recoil. In addition to that, we do see that it does improve some heart function. And when you have super overinflated lungs, that puts pressure on the heart. I tell people all the time, the heart and lungs are neighbors, both physically and kind of biochemically. When you have a lot of this stuff going on in your upper chest, it makes it much more difficult for your heart to beat. Heart to pump out the blood. And so when you take away some of that pressure, your heart's a little bit more effective, which makes your lungs happier, which means that you tend to have less shortness of breath. And we believe that's a factor in with lung volume reduction too. The good thing with this is we do see some benefits even out at 5 years. A lot of the studies are out there looking at the 5-year mark. People were still reporting improved dyspnea symptoms. About 40% of the people were still saying they had improvements in their subjective shortness of breath, dyspnea, at 5 years. There were improved measurements in the quality of life. The old St. George's Respiratory Questionnaire still saw improvements at 5 years. And people were using less oxygen. Just about everybody who gets this lung volume reduction is on supplemental oxygen, and they are sometimes off, but at least have lower requirements even at that 5-year mark. So this can be a fairly effective method of improving quality of life and lung function, even without the wholesale replacement that's involved in a transplant. Because it does remove a lot of that air trapping, lets you take the more efficient breath, lets your heart beat a little bit better, all that kind of stuff. And the most interesting thing that I found in the research is that this can actually be a bridge to transplant. Having lung volume reduction, it's not necessarily an either or. For a long time it was kind of looked at it as sort of an either or, but it's not necessarily. We've got people who you can put off for a couple of years to find a better match or to do some other stuff. You may decide that you want to opt out of a transplant after having lung volume reduction. This can be a bridge therapy to improve your quality of life while you're on a waiting list, or as an alternative, if you have difficult to match lungs, or if you have other stuff going on, maybe you're not a good candidate for that. This can be another option for you. As far as how you decide, again, the selection criteria are going to be sort of similar to a lung transplant. This is still a fairly significant surgery. This isn't just having your knee, having some of the cartilage taken out of your knee or anything like that. This is still a pretty big deal. And so they tend to do the pulmonary function test to see where you are. They do a 6-minute walk test to check your exercise tolerance. They do blood gases to see how well you're going to tolerate the procedure. They do an EKG just to make sure your heart's in good shape. One of the things that they do for this that really can have an impact on the predicted success is what they call a high-resolution CT scan. This idea of removing some of the diseased lung tissue works best when you have what we call heterogeneous or not evenly distributed emphysema. There are two kind of main kinds of emphysema damage, where we call it heterogeneous, where you have some spots that are sick and some spots that are just fine, or homogeneous or diffuse emphysema, where this is probably most commonly seen in like alpha-1 antitrypsin deficiency, where pretty much all of the lung fields are the same level of emphysema, the same level of damage, and less likely to respond to this kind of therapy. Which kind of makes sense if the idea is to let the healthier tissue have more room to breathe, so to speak, no pun intended. If you don't have that healthy tissue, then it's not going to work as well. So we do this high-resolution CT scan to make sure that it is diffuse, and usually we've seen that people with damage that tends to be more in the upper lobes seem to have better results from this type of procedure. But again, it's going to be kind of that risk-benefit analysis. But it is important to get that CT scan done. And also, must be able to do pulmonary rehab for 6 to 10 weeks afterwards. Again, this isn't necessarily a definitive solution, a one and done kind of thing. This is going to be an ongoing process. And so you have to be able to recover from the process afterwards, and you still are going to have a fair bit of damage in your lungs. So exercise is going to be a key component to this as well, and you have to be able to commit to and be able to access 6 to 10 weeks of pulmonary rehab after the procedure. Now, I did mention that sort of alpha-1 damage, and I do want to point out that because Up to Date also made a point of pointing out alpha-1 antitrypsin deficiency is not an absolute indication to, or a contraindication to having this procedure done. People with alpha-1 have had it done and have had positive results. It's just a matter of trying to find that right candidate, trying to find that splotchy kind of lung damage, so that you have some healthy tissue to work with after the fact. The qualifications for lung reduction, hopefully I covered that fairly well. Jim and Mary checking in from Mexico. Thank you very much for taking time out of some vacation for you. Is that how these coils work? I've been hearing about. Spoiler alert, that's coming up very soon. Actually, that's coming up next. Again, we talk about these procedures not necessarily being the right fit for everybody, and major surgery is not necessarily a good idea for everybody. And so we do have some of these techniques now. You can watch this video that's playing down below here. This first technique is called an endobronchial valve, which is going to work very similarly to the idea of lung volume reduction. You can see this tube is snaked, the bronchoscope gets down into the lung tissue. This is a video that is available on YouTube, and seals off some of the damaged tissue. Instead of removing it, it just kind of blocks it off. And you can see with the video here that the air will go into the lung and will be diverted into the healthier parts, preventing the disease part from inflating, and actually the air can kind of trickle out a little bit. That gets deflated, gets kind of works to reduce the volume internally. As the lung deflates, it gets smaller and smaller and smaller, and then that area can't refill again, and lets the healthier areas take on some of that space, that room to inflate again. The issue with the valves is everybody knows that you have your main airways, your main bronchial tree, so to speak, where everything kind of comes into your mouth, down your trachea, your windpipe, and then out into the lung tissue. But your lungs also have what's known as collateral ventilation. You have once the air gets out into the lung sacs, the alveoli, where the gas exchange happens, sometimes it can percolate through other channels too. It goes from alveolus to alveolus, it goes from bronchus to bronchus. There are a couple of different ways that it can go through, but this whole concept is called collateral ventilation. It's like shortcuts between the lung units. And as you might expect, even if you block off the main channel, if you have a lung unit that has a lot of these shortcuts around it, it's going to get reinflated. And so that kind of defeats the purpose to some of these valves. But again, this is the kind of thing that can often show up on high-resolution CT. We can look for those methods of collateral ventilation. We can look for what we call fissures in the different lobes of the lungs. Sometimes if you have an incomplete fissure, that tends to mean that you have more of these channels of collateral ventilation. But if you have a complete fissure, then you're probably more likely a candidate for the valve. They have been shown, they're relatively new on the market, so we don't necessarily have a lot of high quality data for them, but we do see that they do increase quality of life and exercise tolerance at the 6 month to a year mark. Still waiting on some of the long-term data to come out, but hopefully that is online here. Next up, for if you do have that collateral ventilation, if that is an issue, or you have other reasons that you might not be a good candidate for the valve, are the lung coils that I believe it was Susan mentioned. Yep, Susan mentioned this idea of lung coils. And this works in a similar way. This is again a not truly surgical intervention, where you have this memory wire that is designed to keep a certain shape. You stretch it out, you advance it in, just like the video is showing us here, and you put it into some of those sections of lung where there is diseased tissue. The metal is designed so that it will recover its original shape and collapse down some of that lung tissue. Again, sealing off the airways there, and allowing the diseased part of the lung to collapse a little bit better, and allowing the healthier lung to expand. They put I don't know, 2 dozen of these all around the various parts of the lungs that are diseased, and allow that to shrink down and collapse and get stuff breathing again. The nice thing about these is that the collateral ventilation doesn't matter. This is basically if you were to collapse something down and then tie a string around it so it didn't expand again. That's how these work. These will prevent the lung, in theory, from re-expanding no matter how many areas of collateral ventilation there are. They won't re-expand, and so it'll be easier to keep those parts of the lungs collapsed and doing a better job with allowing the healthier lung to expand. Again, we're seeing quality of life improvements at 6 months to a year. In this regard, and in this therapy, we actually do have some longer-term data. They've been approved in England or in Europe for a little while now, and they're just about on the verge of being approved here, I believe, by the FDA in the U.S. But we do have some long-term data from Europe, where in 3 years at least, 50% of the people who underwent these procedures were still seeing improvements, maintained improvements in their quality of life and their exercise tolerance. So again, this is a kind of a non-surgical, sort of invasive. We're going in, we do have to stick something in you, basically. We have to send it down your airway. So it's not truly non-invasive, but it's less invasive than actually having a surgical procedure done. A couple other things that are out there that are a little less data on, but kind of the same idea. There's a sort of glue and adhesive that works very similarly to what the valves would do, I guess, where it can glue some of those airways shut and prevent them from getting the air in. There's also what we call thermal ablation, where we basically send in a heat probe, burn some of the tissue there and cause it to scar over and seal off in that way. But again, less data available on those. They're not practiced nearly as much, nearly as often, and so we don't really know much about how well they're going to work, especially over the long term. Our biggest things are going to continue to be improving our transplant procedures, improving that lung volume reduction, and then these bronchoscopic approaches. So that in summary, how are we going to decide which one is which? Well, again, it comes back to that concept of personalized medicine, where we're trying to do the right procedure for the right person. It's going to very much depend on what else is going on inside your body with your other symptoms and everything else that's going on. We need to look at the variety of risk to benefit ratios, where every surgical procedure has some measure of risk. Arguably some of the most dangerous part, even with like lung transplants and things like that, are what we call the perioperative period, right around where the procedure is, where you're at the highest risk of infection, the highest risk of complications. It's going to be like that with a lot of these other things. There have been complications reported even with coils and things like that. Somebody had I believe at least one patient had a pulmonary embolism, or a blood clot that kind of damages parts of the lung tissue. There are risks to these procedures, but they do also tend to have a lot of benefit. And so, as with anything, whether it's medication, whether it's exercise, whatever it is, we need to look at the risk-benefit ratio to make sure that we're making the right decision for your case. And finally, a lot of this stuff is still looking for long-term data. Our longest-term data, lung transplant, we're looking at 30 years. In the scheme of things, that's not necessarily a long time, especially since we haven't really optimized our techniques probably for only for 10 or 15 years now. We're still looking for long-term data on some of the bronchoscopic approaches, some of the lung volume reduction. We're still looking at what is going to be best 10, 15, 20 years down the road, so that everybody can live as happy and healthy a life as possible, regardless of what procedure we choose. So the decision of what procedure to use is going to be a very personal one, to be discussed with your primary care provider, with your pulmonologist, with your area transplant team, or whatever transplant team you're comfortable with. The lecture I was at the other day, there was a person who actually moved closer to the transplant center because they were getting very good results with, I believe they were listed originally at Vanderbilt, but they had a better vibe with the team at Duke, so they actually uprooted their whole family and moved closer to Duke so that they could get into that program. So it's going to depend heavily on your individual situation and your desires and what you want to be. This is, again, we got to row the boat together so that everybody is living their best life. So hopefully that gives you a little bit of insight in some of the processes and some of the therapies that are coming out down the pike here a little bit. I'm going to back up just a little bit. This is now question and answer time for everybody. So if you haven't put in a question, I'm going to scroll back through and find all this stuff here in just a minute. But make sure you're getting your stuff in now. I do want to throw in there, Kathy, the coils are not yet approved in the U.S. I do know somebody who has been involved in a trial regarding the clinical or the coils. They did mention that their pulmonologist, who was one that was involved with the trial, recently got a call from the FDA. Nothing has been announced yet, but usually that means we're moving at least along the pipeline. They are approved in Europe. I can't think of any reason that they're not eventually going to be approved in the U.S. It's just bureaucracy must be served, unfortunately. We all know how that goes when we're dealing with things like the FDA. So we're going to scroll back through while people are getting their questions in and all that stuff. Again, appreciate everybody being a little patient. Did get a late start today. If you are, patient in doctor's office, 20 years in, I assume that back with the lung transplants, that's fantastic. Janice mentioned being evaluated for a transplant is very extensive. Barnes Jewish facility, it was a 2 to 3 day process. I think that's probably pretty consistent. It's certainly consistent with everything that I've heard. I've heard at least 2 days for everybody because some of these things are time consuming at baseline, and then on top of that you have lung disease. I mean, there's a reason you're going for your transplant. You can only do so many PFTs and all the other tests in a day without passing out, basically. So it is a time consuming procedure. If you don't happen to be near a center, you're probably going to be traveling and needing to stay in a hotel and that sort of thing. So appreciate everybody being lung donor or organ donors in general. Michael mentions the issue with the DMV and people not understanding you can save somebody's life by the donation or even make their quality of life better. Absolutely. Again, I know that there are certainly philosophical, religious barriers to some of that stuff, but anybody who can be an organ donor, please, 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 sign up to your organ donor registry and make sure that your wishes are known. Janice says, I was told still in too good a shape. That was their opinion, not mine. That's fair. We talked a little bit last week about how caregivers and patients sometimes have different interpretations of symptom levels, and I think that's definitely true with clinicians and patients, people living with COPD. I don't have to breathe through your lungs. I don't have to deal with what you deal with. So it's difficult for me to say that, you're not sick enough. And that's why I very, very assiduously try to avoid using that. I can look at spirometry, I can look at the CAT scores, your quality of life scores, and I can say, well, according to this, you should be feeling better, and if you're not, then maybe there's something else we need to look at. With organ donation, it is a little bit trickier just because we do have to look at a lot. There are a lot of variables to look at. But I can certainly understand frustration between what somebody else's perceived symptoms are and what you perceive your symptoms to be. So hang in there, keep fighting the good fight, and try to deal with that. David asks, why is the average lifespan so low with a lung transplant? It seems like the new lungs would allow you to live a longer and better quality of life, not less. That is generally true from a strictly mechanical point of view. But again, if we go back to talking about lung transplant, it's kind of trading that one element, one chronic disease for another. When you have a donor organ, your body is immediately trying to get rid of that organ. It looks at it as an intruder. It looks at it as a pathogen, a poison, a toxin, whatever we want to call it. And so in order to do that, we need to kind of dampen your immune response. Of course, if we're dampening your immune response there, we're also dampening your immune response to things like colds and flu and every other bacteria, every other pneumonia virus, bacteria out there. We're suppressing a lot of your normal bodily functions, and it makes it a lot easier for a lot of that stuff to go wrong. We're seeing that sometimes inflammatory processes kick in, and it damages the new lung tissue just as it would damage the old lung tissue. It's a very complex procedure, and there are a lot of variables, and there are a lot of things that can go wrong. And so we're kind of getting to the point now where people aren't necessarily dying from not being able to breathe. We're keeping people, we've locked that down, we've matched up lungs, we're doing a good job with that, but it's that whole kind of chronic rejection syndrome, I think it has a name similar to that, where we're seeing that is really the main issue down the road, and that's what kind of gets you in the end. Now again, I want to point out that a median is not an average. There are just as many people who live, say, 12 years as do 1 year. That's what the idea of the median is. It's the middle point of the data set. There are a lot of factors that can go into living a lot longer than 6 years, and as we get better data, it's also important to remember that a lot of this data is getting kind of old. Even the study that was published earlier this year, the data was from 4 years ago. Think about how much the world has changed in the last 4 years, and think about how much our knowledge is growing in the last 4 years. That applies to lung transplants too. So if we, 5 years from now, we might be still seeing the same people, and now our median expectancy is 10 years. So it's that's always my biggest beef with looking at statistics like that, is we can give you an idea, but it is essentially impossible for anybody to say, well, you've got this long, this procedure tells us, like, it's all a crapshoot. A lot of it is best guess and predictions and things like that, but if you think about how hard it is to predict the weather, you kind of have an idea of how hard it is to predict lifespan and all that kind of stuff. So I certainly don't want to discourage anybody or even look at it as the average lifespan being so short, because that's not necessarily the case. And again, 5 years of healthy living is probably a good idea. So I'm going to switch back to just our basic. Here we go. Janice mentioned always told not eligible because damage was through majority of the lungs. I suspect that might be the lung volume reduction, and that is true. When we're looking at any of the lung reduction things, we need to see that heterogeneity, they call it, that good spots and bad spots, because if we have too much damage spread throughout, there's nothing kind of to expand and to be healthy again. So that's where a lot of these diagnostic things come into play. Talked about the coils. Hey, there's Sam. Sam again mentioned our inventor, our local inventor here in Navigator, creator of the O2 safety strap. Happy to advocate and evangelize for that a little bit. It does look like a great product. Again, it's hard for me to do a product review with any sense of relevance to anybody who's actually using the thing out there, but definitely fills a need, and very happy to try to get the word out for that. Sam, looking to do stem cell versus lung transplant. What are my thoughts? My thoughts are lung transplant all the way. Unfortunately, stem cells are just not there yet. There are a lot of places out there that are going to tell you that they are, that they can suck out stem cells from your belly, your fat tissue, wash them, do some hocus pocus kind of stuff, shove them back in, and your lungs are going to regenerate themselves. There are some extremely preliminary studies out there that are showing some regrowth in some lung diseases, but it is not nearly there yet. We're probably looking at the scientists that I have spoken with at conferences over the last couple of years are saying probably 10 years at least before we have any kind of real viable, even potentially widespread stem cell therapy. There are, like I said, there are some potential. I think down the road we're looking at that being the option, but in the near term, in the term that's probably relevant to anybody watching this right now, we're probably if it were me, I would be looking into lung transplant. It's just not there yet. I hate to be, it's probably bad news, not what you were hoping for, but I got to keep it real. Kathy, not looking at a lung job. The pneumoplasty. One last question from Susan here. Why, she says one last question. I'm going to see what else is going on here. Why, if some of these procedures are approved in Europe, does the U.S. have such a hard time using that data? Well, again, it's not necessarily we're having a hard time using the data, because that does kind of form the foundation of the application process for doing some of this, the approval process. It's really just our system. A lot of it comes down to our system is different than their system. Our system tends to be a little bit more conservative, not in a political sense or anything like that, but in a wanting to minimize any possible risk sense. We, as a healthcare system in general, and again, I don't mean this to be political or to make any point here, we tend to be very conscious of being sued and being attacked and that sort of thing. So we need to, our process is designed to minimize the risk of that. And so we see, even with as sensitive as it is to that, a lot of times things slip through. You know, we look back a few years ago to some of those anti-inflammatories that were causing other organ issues. Sometimes this stuff, it takes a long time to have a real answer for this. And our system is designed to wait for the answer rather than to try to get stuff out and potentially cause harm. I'm not here to say which one is better. Of course, each viewpoint has pros and cons. My personal view is I would love to see us be a little bit more aggressive and get some of this stuff out there where it can potentially be helpful, but I can see the other side to that too. So it's not necessarily not using it. It's not just a slower process. David, the healthier you are, the better chance of living longer after transplant. In general, that is very true. In general, the healthier, the other healthier you are, I'll say. Of course, you're not necessarily healthy if you're considering a lung transplant, but the healthier you are in other aspects, the better luck you're going to have post-op. And that is, again, where Jim Nelson will be very adamant about that. He talks a lot about how he burned out treadmills during his rehab period prior to the transplant. And of course, a big part, he'll also chalk up a lot of his success to the fact that he was incredibly lucky and had an almost perfect match physically, biochemically, everything else for his body. But a big part of it is making sure that you're in as good a shape as possible. You're exercising as much as you can tolerate before and after, and sticking with that after. That's key. Exercise and nutrition, we talk about it a lot. We overlook it a lot in a lot of our maintenance plans because we want to focus on medications. We want to focus on some of these procedures. But diet and exercise are going to be a couple of your biggest indicators for overall health, even post-transplant. So definitely true there. I think we've got a couple of, no, okay. Well, we've got pretty much it on questions here. We're going to start wrapping things up. This is, of course, going to be taking a couple, and you're welcome, of course, Susan. Thank you for tuning in today. Appreciate everybody spending a little bit of time on their Friday with me today. This is going to be it for a couple of weeks. Next week, spring break, going out to San Diego. If anybody's out in the San Diego area, shoot me a message here at COPD Navigator. Let me know and make sure to say hi. Got a conference and some family fun out there. In 2 weeks, I will be at the Michigan Society for Respiratory Care spring conference, talking about a lot of the stuff we talk about here at Navigator, talking about rowing the boat, talking about trying to coordinate care and improve our communications between clinicians so that we can take better care of you and make sure that you are a part of the team. And then in a couple of weeks, I haven't posted them in the group yet, but we are going to be getting back into our, not next week, not the week after, but the week after that, we're going to be getting back into a good medication review. Haven't done one of those in a while. Probably want to try doing one of those quarterly. A lot of people have questions. That's probably the single biggest area of questions I get in our group here on Facebook, COPD Navigator. So it's always good to review some of that stuff, and that's what I do with my people here in the clinic. I always do a monthly review of technique and all that stuff. Plus, we've got some new toys to play with, and we'll show you how we're evaluating your inhaler technique with the state of the art these days. So looking forward to seeing everybody in a couple of weeks. I do hope to be able to send some live video out from our MSRC conference, but I can't promise that. I've tried to promise that in the past couple of years, and tech issues have stood in the way here and there, but we're going to try and get that going. You can get a look in the world, or a look inside the world of how respiratory therapists have fun and learn from each other. But in the meantime, I hope everybody has a very happy Easter. Hope everybody has a good couple of weeks. Take care of yourselves. Take care of each other. If you do have any suggestions for future episodes, future topics to cover, any questions in general, please join us. We have a page on Facebook, facebook.com/COPD Navigator, with a link to our Facebook group here. Despite all the drama and everything else covering Facebook, we are sticking with it for the foreseeable future at least. This is a solid platform, and I promise that I won't sell any of your data and I won't give it to any Russian spies. So bear that in mind when you're joining us. I hope you can also find us on YouTube. In order to fill the gap in the next couple of weeks here, I'm going to catch up on some of the episodes that I haven't been able to get up on there, but you'll be able to find those down there at the link below. If you are so inclined, please subscribe on YouTube. Once I hit a certain number of subscriptions on YouTube, I can actually change the name of the channel and make it easier to find. So we'll call that COPD Navigator. I believe I need 12 more people to subscribe to me on there. Once I hit 100, I can change that to Navigator, make it easier to find. So subscribe. Again, take care of yourselves, take care of each other, and I will see you in 3 weeks here at COPD Navigator Live. Take care, everybody.